So who's the first presenter today?
นี่ค่ะ
Prava, right?
ค่ะ
Okay. You ready?
yeah
Okay. Let's
Okay.
start.
okay ค่ะ so today we're going to talk about the common dislocation in orthopedic. I'll be responsible for the shoulder dislocation. For the shoulder dislocation, first we're going to talk about like important anatomy that we should know that associated with the dislocation. So first, for the glenohumeral joint, it's a ball and socket type of joint, so it can move in all direction, so it like can be easy to dislocate it. And next, for the component that responsible for the static stability will involve bony anatomy of the shoulder, the capsule, and the labrum. And the labrum is the most important like structure for the static stability, and for the dynamic stability are like those muscle which include rotator cuff and bicep of the long head of the biceps. And for the shoulder dislocation, actually we can divide it into a traumatic or atraumatic. For the traumatic event, for the anterior dislocation, typically the patient, for the mechanism, it will be arm abduction, so over here, and then extension and external rotation, and there might or might not be an anterior force over here. So if the mechanism is like this, the patient will get an anterior dislocation, and it's the most common dislocation. And for the it can also present as like episode subluxation, as we often see in the ward. And also for the posterior dislocation, the patient arm will be abduction and flexion and internal rotation. For the posterior dislocation, it's actually common associated with seizure or like electrical shock. And next, for the non-traumatic, it due to like capsular and ligamentous laxity or muscle weakness, so it's like more common in like patient with previous trauma or maybe elderly. And like when there's a shoulder dislocation, it will lead to like instability, so it can be easy that the patient might have a recurrent episode of the shoulder dislocation.
Okay. So which one is more common, the anterior and posterior dislocations?
The anterior.
Yes. Anterior is more common, right?
Yeah.
It's not just this position, abduction, external rotation. Sometimes it can happen like you fall on outstretched. Okay, but the arm is like this, yeah, pushing to the back like this. Okay, push like this, yeah. So it can be happen also, right? Not always like abduction, external rotations. And for the posterior dislocation, it's opposite. Like I showed you this morning, right? The patients that have the posterior shoulder instability, they were like this, yeah. Sometimes there's something hit the elbow, right, like this. Okay. Or sometimes like electric shock or seizure, patient may have dislocation to the back. Okay. It's much less common comparing to the anterior dislocation. Okay, next.
So we're gonna talk about like typical clinical manifestation. First, for the anterior dislocation, the history will be like a sudden event, and mostly it will be like overarm position, so it's more common in like overhead spot. And the patient will feel like sudden pain, and then he or she might feel like the feeling of like instability. So after the treatment, after we like we track it back, the recurrent rate actually is like quite high for the patient under 20 years old, so it can be up to 90%. So for the recurrent, it can be either recurrent subluxation or recurrent dislocation. So for the subluxation, the patient will be like catching like the sensation, and they might present with numbness and weakness. And for the recurrent dislocation, it happened when the patient perform like an overarm movement, but like they don't like typically it doesn't have to have any like traumatic event too. They only have to perform overarm movement, and the shoulder will be dislocated. So for this one, we have to manipulate it back too.
So there'll be subluxation and dislocation, right? Subluxation means it's not complete dislocate. Okay, patient feel like the shoulder is getting out, but it's just some part. It's not completely dislocated because of subluxation. Okay, but dislocation, the meaning is that it's complete dislocation and need to be reduced. Okay. Good. Next.
So for the posterior dislocation, it can also be given to like acute dislocation or the chronic instability. For the acute, it happened, like I said, after like high energy trauma or seizure or electric shock, and the patient will present in like an arm sling position, so flexion, abduction, and internal rotation. But for the chronic instability, the presentation will be pain on repeated like microtrauma in arm sling position like this, and the patient might or might not feel the instability of the shoulder.
So it's common miss because the deformity is not obvious. Comparing to the anterior dislocation, you can see obviously the shoulder is deformed, right?
Yeah.
You can see the gap. You can see that the shoulder is deformed. But with the posterior dislocation, you look in the picture. Can you see any deformity? No? Yeah, it's not obvious, right? On the left side. Left or right side?
I think it's the right because the shoulder is like going down.
I don't know which side, left or right, because it looks the same.
Yeah.
Yeah, but it's look carefully. There will be like fullness. Oh, no. There will be like the posterior part of the shoulder will be like fullness, and the anterior part you can see that there's some like dimple. Okay, but sometimes if the patient is fat, you cannot see obviously. You can see obviously in the skinny patients. Okay, but it's common misdiagnosis. This is one of the common misdiagnosis. Okay, good. Next.
Okay. So next we're gonna move on to the physical examination. For today we're gonna talk about like special tests. So the first one is for the anterior dislocation. For the left side is the Hamilton ruler sign. So basically it represents that the deltoid is flattened because like you can put down the ruler and it will touch like the acromion and lateral epicondyle as like a straight line, but normally you can't do that. But like the reason why you can do this is because like the head of the humerus moves down and medially, so like the deltoid mass is like moving down and it's gone, so it becomes straight instead.
Yeah, the deltoid will be flat, right? So you can put the ruler between the lateral epicondyle and the acromion. But in normal patients, you cannot do that, right? Because of the deltoid muscles. Okay.
And another one is a Dugas test. So basically, you tell the patient to like cross to touch another opposite shoulder with the kind of 90-degree flexion, and the examiner try to push it down, and it will be positive test if there's like a pain, which indicate that they have an anterior dislocation of the humeral head. Go like this and go down.
Touch the opposite shoulder, okay? Because the anterior dislocation, this is positive in anterior dislocation, but in posterior dislocation, can the patient do that, Duga? Preva can or cannot in posterior?
Posterior, I think so.
Can or cannot? Can, yeah, because the patient already in adduction internal rotations.
Or like this.
Okay, but for the anterior dislocation, the arm will be in abduction and external rotation, right? So the arm cannot touch the opposite side because you need to do adduction and internal rotation. Okay, so the Duga side is specify only anterior dislocation. Okay, next.
for the next one is the apprehension sign. Actually, for this one, there's like two type, anterior and posterior apprehension sign. So for the how you perform this is that you do 90-degree abduction and a 90-degree of elbow flexion, and you either like external rotation or internal rotation. For the external rotation, it will be for the anterior apprehension test, and for the internal rotation it will be posterior. And the sensation that the patient should get is the apprehension, not the pain. So like yeah. And this will detect for the instability.
Actually, the light picture is the relocation test. The left picture is the apprehension, right? And when the patient had pain, you push the shoulder to the back. That means you preventing the shoulder getting out, right? You push it back, so the feeling of pain will be gone. Okay. CJ Cat,
just go back.
Saka, you have video of relocation test.
Here, I'll share.
Yeah, please find and let me know and share to the students. Okay. You have that now or later?
No, not the test, sir. Only the reduction.
Okay. Fight.
Yes, sir.
Relocation test. Okay.
Yes, sir.
Okay, next.
Okay, next test is the jerk test. As we see, Ajahn did it today. So basically, the arm will be 90-degree abduction and elbow flex 90-degree and internal rotation. And this one we're testing for like a clunk or like a jerk sensation. And can you play the video?
So you elevate 90-degree, right? And then performing the axial loading, right, to the elbow, like this, okay? And then the patient would feel pain, okay? So we call this the jerk test or the posterior apprehension test. Okay?
I found a video of the relocation test, sir.
Okay. So Prava, Kat want to share the relocation test. Kat, open the video also.
Okay, sir. Then I need to share my screen.
Okay. I mean your face. You don't want to share your face.
I don't have backgrounds.
Oh, no problem. Okay, share the students.
Can I share my screen?
Okay, so Prava, you need to stop the sharing first.
I think Manny is sharing. Oh, okay.
Okay. There. Yes, sir. Can you guys see my screen?
Yes.
So.
This is a relocation test.
Yes, sir.
Do you have the Thammasat relocation test?
No, sir. We don't have, sir.
So first you are applying the apprehension first, right? And then you push it back.
Yes, sir.
Okay, like Prava, you like your pictures, right?
Yeah.
Yeah, show. Okay. So when the patient have the feeling of the pain or the feeling like the shoulder is getting out, then you push it back. Okay. You
Yes,
push
sir.
this back. The feeling of dislocation will be gone. Okay. So we call this the shoulder relocation test. Okay.
Yes, sir.
Okay. Prava. Next.
Okay, so the next is that we can do the posterior stress test.
The same
also
like
for-
posterior apprehension. Same.
Yeah. Okay. So we just put it down. Okay, so now we're gonna talk about the associated injury that we should know, so we can be looking at it. For the associated injury for anterior dislocation, there could be labral tears. There can be fracture of the glenohumeral rim, which we call it the Vanguard lesion, and also the humeral head impression, which we call it Hillside lesion, and there could be a fracture of the tuberosity. It also common that there will be a rotator cuff tears in the elderly, and they can be an axillary nerve injury, which the patient will present with numbness over the deltoid insertion here.
So the dislocation in the young and in elderly is not the same. Okay, Pravan, can you tell the difference? This one. This is the Kim test.
This is Dr. Kim, sir.
Yeah, this is Dr. Kim. The Suho Kim. This is original Kim test, you see?
Yes, sir.
So he's a baseball pitcher, this one, okay, and has pain. So the original Kim test would be like axial loading. Say like this, okay? Axial loading and push the shoulder post-low inferiorly, okay? Like this, okay? This is the original Kim test. Like I showed you this morning, okay? Okay, good. Thank you, CJ.
No way, sir.
Thank you.
England, share the video again, your presentation. Okay, next.
Okay, so I'm gonna try to answer your question. So for my understanding is that the main difference is that the associated injury that you can find with. So for the elderly, it's common to see the anterior dislocation with rotator cuff tears and also the axillary nerve injury.
In elderly,
Yeah.
the associated injury is
the rotator cuff tears
yes, and
the nerve injury.
And nerve injury. Very good. Okay. And also sometimes the tuberosity fracture. In the young, it's not common to have the tuberosity fracture, like greater tuberosity fracture. Okay. And also the recurrent rate in elderly is less comparing to the young. Okay. So in the young, common pathology is the labral tear, like you say, Vanguard lesion, Hillside lesion. And also most of the time there's no nerve injury. Okay. But some patients also have axillary nerve injury. Okay. Depends on the severity or mechanism of injury. Very good. Next.
And next is for the posterior dislocation. So it's pretty much the same. So there can be the labral tear, which is the posterior side. So we call it posterior Vanguard lesion. The fracture of the lesser tuberosity, the posterior glenohumeral fracture, which is the bony Vanguard lesion, and also the humeral head impression. But on this one will be reverse Hillside lesion, and also the rotator cuff tear is common in the elderly too. Okay, next. So we're gonna start talking about the imaging. So normally for the shoulder, we would send the AP view and the Y view, but for the axillary view, we will send it if we suspected of the posterior dislocation. It's actually very painful. So in like common practice, we rarely use it. Except and next slide.
Very good. Yeah.
And this one is the picture of the anterior dislocation. So as you can see in the AP view, so the shoulder will move medially and inferiorly, and also in the Y view you can see that the head will be in front of the Y.
Okay.
And for the next slide, please. For the associated injury that I talked
So
about.
axillary view is anterior posterior dislocation in this picture. Go back.
Sorry. Back.
Is anterior of posterior dislocation.
It's anterior.
Are you sure? Are you sure? Where is the coracoid process?
It's another side. The coracoid process is up there.
Where is the coracoid process? Where is the clavicle?
The clavicle is it the in front?
Yeah. So this one, the head move to the back or move to the front?
To the back.
It's moved to the back, right? Yeah. So this is posterior dislocation. Right,
the picture is wrong. Yeah,
No problem. Because most of the time we did send the patient for axillary view in the anterior dislocation is quite painful, right? So this is a good pictures for the posterior dislocation. Always looking for the coracoid and the clavicle, right? This true structure is in the front. So the head move to the front is the, yeah, but now head move to the back, right? Okay,
Actually,
next.
I think the picture up there is different from the picture I have here.
Mm-hmm.
I don't know why.
Yeah.
Yeah, but I think the picture is wrong. But okay. So next is the associated injury that we talk about. So first, the Hillside Lesion is the depression in the humeral head over there. Maybe can you point out? Yeah, over there, the Hillside. And for the Vanguard lesion is the reduction of the glenohumeral labrum. So it will be like a bony part down there.
Mm-hmm. So the Vanguard can be soft tissue or can be bone, right? So if there's no fracture of the anterior rim, we call this soft tissue Vanguard. But is there some bone fracture at the rim, we call that bony Vanguard, okay? Or osseous Vanguard lesion. Okay? For the osseous Vanguard lesion, is the indication for surgery. Because if you do not perform the surgery, over time this bone will be resolved and the shoulder will lose and very high chance of dislocation. So nowadays, if the patient have osseous Vanguard, we prefer to do the surgery. Even this is the first time dislocation. Right, Kat? Yes or no?
Sorry, I was muted.
Yeah, okay. So don't forget to look for the osseous Vanguard, right? Okay, next one.
Next is the posterior dislocation. So the sign that we can see is the light bulb sign. It's because like the humeral head is like internally rotated, so the tuberosity cannot be seen so clear, so it appears like a circular light bulb sign. And actually there also will be like the widening of the glenohumeral space.
Yes. We call that vacant glenoid sign. This widening of the glenohumeral joint space, right? But the deformity is not obvious, right? If you look and you can easily miss it. Yeah, sometimes it looks very normal. Next.
Next, that's the axillary view. Okay. And that's the Y view. So you can see the Y view is the posterior to the Y. And actually there's like indication for the MRI for the posterior dislocation, which include the chronic posterior instability. And if you're suspected of any associated injury, such as the labral tear or reverse Hillside or rotator cuff tear. So we're gonna talk about the reduction. So the first one is the Milch maneuver. So can you play the video too? So basically you do like downward traction and external rotation and then abduction of the limb.
See that the patient is awake. So you talk to the patient all the time and let the patient relax. Okay? So you can easily reduce traction all the time and slowly abduct and external rotate. Okay. Now the pain is gone and you can gentle move the shoulder. Okay, and followed by going down to the duga position, right? If you can do this position, that means the shoulder was already reduced, right? We call this the Milch technique. Okay, next one.
The next one is the traction, counter traction. Next one. Yeah, so basically this one is the 3-way point force. Play the video, please. So when a person cool down.
Yeah. So but this technique always needs some sedation, like diazepam injection, petidine injections. So the point is that you need to let the patient relax. Yeah. If the patient against you, maybe it's not possible. Or sometimes it's a patient with very big size, like muscular man, crab man, like Christian CJ, right? So sometimes it's not possible to reduce. So you need to send the patient to the operating theater for full sedation and reduce. Okay. Yeah, this way. Okay. Traction, contraction. So the trick is that when you do the traction, you need to be very steady, not jerky traction, very steady traction. Okay. And the rotator cuff will reduce the head back. But this is another modified traction contraction. In case you have no rotator cuff or cuff tear or tuberosity fracture, you see that? In my hand, there's a towel, right? So I need the third force to pull the proximal arm back. Yeah, this act like the rotator cuff, okay, to reduce the humeral head back. So we use this for the patient that have cuff tear, tuberosity fracture, okay, or in elderly. Yeah, this is safe way, okay. If the patient have the tuberosity fracture, cuff tear, or large Hillside lesion, you should not do the Muse technique like I show you because you can create a fracture. Because when you try to elevate the arm like this, okay, you can create the stress on the Hillside. You can create the stress on the humeral head, and it can be broken. Okay, so the traction bed is safer, right? Next.
Let's see. Next are some of the technique that we don't usually see. For the first one, it's a Simpson Maneuver. So basically, you let the patient hang on the table and you put like a weight 5 to 7 kilogram and you let the patient like stay there for 20-25 minutes. And it said that the traction will overcome like the muscle spasm and the shoulder will get back in place. And the Hippocratic Maneuver is an ancient method that we don't usually use anymore. So that one, the patient lay like supine on the table, and the examiner will put like a foot on like the axillary area, and they will like counter traction the shoulder down. But
It's
this
not
one,
recommended nowadays, okay?
Yeah.
Because your foot, you see, shoeless, may create, it look very barbarian, right?
Yeah.
Yeah, so you can damage the brachial plexus, yeah? But it's not polite also, yeah, to use the foot to do that way, okay? So we stop doing that. Yeah, Hippocrates. But actually, there's a good method because you can do this without any assistant, right? You can do it by yourself. Okay. But I think in this situation, you may have your assistant. It's the same concept like the traction, counter traction, right? Okay, next.
Next is the after the reduction. So first we're gonna put the patient in the arm sling, but we can only put like the arm sling in for like 1 to 2 weeks because it will be stiffened if it's more than that. And we should advise the patient to avoid like the external rotation and adduction of the arm. And after we put the arm sling, we need to advise on the like cuff exercise to strengthening the muscle over there for the dynamic stabilizer.
Yeah. So in case the patient have simple dislocation, the pain will be gone very fast, like 1 or 2 weeks. So you just link for 1 or 2 weeks is enough, right? But if the patient had the persistent pain, I mean, after 3 weeks, after 4 weeks, the patient still have pain. Win, what do you thinking about?
like you maybe like film again to see if it is like reduction, if it moves out from the reduction.
Okay, very good. And next, what else?
Like consider surgery if it consider like reduction again and work up for like the underlying
If you
cause.
X-ray and there's no dislocation, it's still in press. What should you thinking about? Which associated injury that produce pain, even the patient was reduced. X-ray look nice, but still have pain. England, do you know? Many infa.
Is it the labral injury? Maybe the labral injury.
No, laboratory does no pain.
Maybe like the reduced, like it pinched the nerve, or
What? Infa, I cannot hear you well.
maybe like the reductionกด nerve, it like impinged on the nerve.
Nerve compression, no.
Nerve
Many. Huh?
หรือเป็น fracture ได้ไหมคะ like the bony Vanguard lesion or the reverse Hillside lesion that we talked about earlier, maybe at first.
Yeah. If the X-ray look the same, but the patient have persistent pain. So CJ, what is that?
We can consider, sir, a cartilage injury, sir.
And what else?
And,
Saka, Max, Cat, you
Sir,
know?
glenohumeral ligament injury, sir.
No. Max and Cat, do you know?
It's not the labrum, sir.
No, the rotator cuff. Yeah, if the patient have persistent pain after the reduction, thinking about the rotator cuff, that produce a lot of pain, you know. Just the labral tear or dislocation, the pain will resolve in few weeks. Okay? But if the patient have persistent pain, you should consider to send the patient for MRI. Okay?
Yes, sir.
Especially in middle age or elderly patients. Okay?
yes, sir.
Okay, next. Paiwa.
Next is just we're gonna talk about when we should do the operation. So the indication include like the frequent dislocation or like the fear of the recurrent subluxation after like even though like rheumativity, and there's the patient has to perform a high risk activity such as they're like athlete, and if there's a glenoid bone loss and also the Hillside lesion. So the main principle of the operation is that we need to repair the defect, such as the Hillside and Vanguard lesion, and we have to like tighten up the capsule to prevent it from dislocation. And there's like many techniques that we can do according to the patient lesion.
Very good. So that's enough for the medical student, you know. You should know the mechanism of injury, how to reduce it, and how to treat the patient after the surgery, and advise the patients, okay, to avoid the redislocations. Okay. CJ, Kat, and Sika, can you show the one example of the surgery?
So, sir, this is one case of yours. This is arthroscopic Vanguard repair. And so for everyone, this is an arthroscopic image of the shoulder. So shown in the image is the application of the suture anchor. It's an implant we use to repair the labrum. So you can see the edge of the glenoid and the labrum. So what the principle of the Vanguard repair is we try to restore the anatomic position of the torn labrum together with the capsule, which will prevent subsequent or recurrent dislocation.
Mhm.
So we do this by using an implant called suture anchors. So the suture anchor is a screw that is engaged to bone, and at the tail of the screw are sutures, and the sutures are tied around the capsule tissue or the labral tissue. And these tissues are tied back to the bone. So as you can see, so as the suture anchor is applied to the edge of the labrum, you will see sutures around the labrum, and this will attach the labrum back to the glenoid.
Mhm. So this
Yeah,
is
so
very
this
old
is-
video.
Yes, sir. Yes, sir.
You choose this one. It's very old.
This is an old one, sir.
Mhm.
So here you can see an instrument used to capture the labral tissue.
Okay, make it fast, CJ. Just show one stitch enough.
And then
Tie
the
the knot.
suture is tied around the labral tissue, and it's tied. And this is how we secure the tissue back to the glenoid.
Mhm. So we do repeat the same step for about 5 or 6 knot, okay, for the instability. So finally the shoulder will be stable again, okay?
Yes, sir.
Okay, thank you, CJ. Stop sharing. So next, Frewa, you finished, right?
ค่ะอาจารย์
Okay, very good. Who's the next?